So good afternoon, ladies and gentlemen. My name is Tomáš Hucl. I'm a gastroenterologist from Prague, and it is my great pleasure to welcome you to this satellite symposium entitled The Modern Interventional Mindset by Sonoscope. Sonoscope is a hugely expanding company with most interest in endoscopic ultrasound and advanced imaging of standard endoscopes, and these topics will be covered today in the satellite symposia by our two very distinguished guests. The first one being Dr. Fernandez from Spain, who will cover the first topic of endoscopic ultrasound, Dr. Fernandez, and the second one being Dr. Herreros De Tejada, also from Spain, who will cover the second topic of magnification of standard endoscopes. So I'd like to first ask Dr. Fernandez also some technical information for you, those of you who do not want to come up to the microphone, or those of you who are watching us online. You can send your questions to us using the online platform. We will read them to our speakers. So please, Dr. Fernandez.
Thank you very much, Thomas, for your kind presentation. And as he says, I'm Dr. Fernandez. I come from Vitas International Hospital in Spain, and it's my pleasure to be here. I want to really thank Sonoscape and the organizers of this symposium, their kind invitation to this lecture, which I'll call my EUS teacher, like we will discuss later on. First, here is my conflict of interest. And recently I watched a documentary. We're going to talk about the past, the present, and the future of the endoscopic ultrasound. Recently I watched a movie with a documentary called My Octopus Teacher, where the narrator talks about how his relationship with the world changed after he became a friend of an octopus. It's a pretty nice film. So when I was proposed to talk about the EUS, I thought that we could discuss how our relationship with our patients has changed since we have the endoscopic ultrasound, and how our approach to them has changed. So to get context, we will review where do we come from. The first time an endoscope was modified to wear an ultrasound probe on the tip was in 1980 by Professor Di Magno at the Mayo Clinic. He succeeded to explore internal organs of several dogs next to the GI tract. 16 years later, the ESGE guidelines published the first guideline on endoscopic ultrasound. Ever since then, EUS has evolved from a pure diagnostic instrument to a sophisticated tool for intervention and even for the invention of new devices. Now we're going to review some of these gadgets. We're going to focus on how the clinical management of the pancreatic fluid and solid collection has changed along the time. They are common complications in pancreatic diseases. Back in 1975, it was the year of the Bohemian Rhapsody song and the invention of the Rubik's Cube. Also in 1975, it was the first time ever to gain access to a pancreatic fluid collection when Dr. Rogers drained a pseudocyst by directly puncturing it in blind mode to empty it. The patient didn't feel any relief, and 2 days later, an image revealed the cyst was fulfilled again. 10 years later, in 1985, when the song We Are the World or the movie Out of Africa were released, Kozarek performed the first fistulotomy with a needle knife in 4 patients. Remember that by then, the clinical management of this patient remained surgical. Complete resolution of the cyst was achieved in 2 out of 4 patients with this technique. By the time Microsoft Windows 95 was released or Toy Story succeeded in theaters, Professor Wim Muller published a paper evaluating endoscopic drainage of 20 cysts. One of them was located by endoscopic ultrasound, as it made no bulging in the stomach. Plastic stents were placed, and 19 of those 20 cysts were resolved by this technique. A year later, Dr. Wieserma and others used for the first time an ultrasound endoscope prototype with a working channel to locate a cyst, puncture it with a needle knife, withdraw the knife, leaving the catheter in place a guide wire through the catheter, remove the catheter, leaving the guide wire, and place advanced 4mm balloons, dilate the fistula, and place a plastic stent over it. So it was the first time a fluid collection was successfully drained with an ultrasound endoscope. When the century was changing, the first endoscopic retroperitoneal access was achieved as the first endoscopic necrosectomy was performed by Professor Seifert in 3 patients. All of them were discharged after a small follow-up. Even a subtotal splenic resection was performed with a needle knife and a snare. This is 20 years ago, and still the clinical management of these patients remains surgical. Few years later, Dr. Pérez Miranda communicated the placement of covered self-expandable metal stent in 3 walled-off necrosis and 1 pancreatic abscess with technical success, allowing direct necrosectomy through them. The final therapeutic success of the self-expandable metal stent was approximately 75%. But the main handicap of these stents is the migration. Up to 40% of them may migrate. At that time, the AGA, the clinical guidelines of the AGA recommended managing solid collections with surgeons surgically and liquid collections through endoscope or percutaneously. In 2012, everything changed, and not because the Dark Knight Rises or the Avengers arrived, but for the development of the lumen-opposing metal stent and its improvement a couple of years later. And so we arrive to the current moment. A recent meta-analysis compares the outcomes of surgical and endoscopic necrosectomy, concluding that endoscopic approach has lower complication and lower mortality. Also, there is a recent analysis comparing surgery versus percutaneous or endoscopic necrosectomy, concluding that endoscopic approach is much more cost-effective because of the less mortality and less hospital stay. As necrotizing pancreatitis is a heterogeneous disease, there is no one and only treatment for them. There are several conditions where the endoscopic necrosectomy has no relevant paper so far, like paracolic artery extension of the necrosis or the pelvic extension of the necrotic tissue. Anyway, thinking what it was like 15 years ago, I'm still shocked every time we perform a cystogastrostomy. How a technique that is no longer than a couple of minutes is changing our patient's evolution. It's very comforting to see how a patient improves drastically within 24 hours when undergoing this technique. This is real-time video, and it's no more than 2 minutes deploying the lumen-opposing metal stent. We had even a fellow that day in the room learning how to deploy, how to manage this device. This patient stopped having temperature the same afternoon, and he was discharged last Monday after 4 necrosectomies, 4 sessions of endoscopic necrosectomy. Although we have focused on pancreatic fluid collections and solid collections and walled-off necrosis, nowadays there are a lot of indications for therapeutic endoscopic ultrasound, like biliary access, enteral anastomosis, tumor location and therapy into the tumor, liver application, or vascular access. And all of them share same story or compare a story as we have just reviewed. So, what do we expect now from the endoscopic ultrasound? There has been a huge growth in pancreatic and biliary access drainage techniques or enteral anastomosis, mainly due to the development of the LAMS. Nevertheless, there are no randomized prospective trials to compare different approaches, so quality data is needed to be sure that we are doing what's best for our patients. Although pelvic collection drainage through endoscopic ultrasound is described, there is a lack of standard procedure and the standard indications for these complications. And we also miss specific devices to perform necrosectomy. Although nowadays it's quite common to perform gastrojejunostomy for gastric outlet obstruction, sometimes it's very tricky to puncture the bowel because it moves. It would be desirable for us to develop devices to stabilize the bowel when we perform gastrojejunostomy, so we can perform it safely and for us to be more comfortable. As you're aware of, in the past few years, liver biopsy EUS guided has been described, and it will probably become the gold standard in the near future. Anyway, we are still using needles developed for pancreatic tissue acquisition, and we would like to have some more specific needles to perform this kind of biopsies. Although with modern equipment it's quite easy to perform elastography, we would like to see some more improvements in shear wave elastography so we can have an accurate degree of fibrosis in the same procedure. Nowadays, artificial intelligence is everywhere, and also in endoscopic ultrasound. It has been tested to assess its diagnostic accuracy and even compared to expert endoscopists in subepithelial lesions. And you know that artificial intelligence is more accurate than humans. But I think it's furthermore interesting the on-site evaluation of the acquired tissue, which so far has been proved to be as accurate as human. If you cannot do rapid on-site evaluation, like myself, I have never had a pathologist in place when performing a biopsy, I think this is a very, very promising pathway. So to conclude, endoscopic ultrasound has changed in the last 15 to 20 years how we manage our patients. Although there is a lack of quality data and we need to perform more studies. There is as well a lack of training, we haven't discussed about that, but there is a lack of training in resident physicians, and there is quite a promising future in the artificial intelligence, especially for on-site pathological evaluation. That's all. Thank you very much for your attention.
Thank you, Francisco, very much for this great lecture. Also nicely demonstrating the huge development that has happened in the field of endoscopic ultrasound. We decided to allow a few questions now because the two topics are sort of different. So in case there's someone interested only in the first topic, so please feel free to come up to the microphone. I would start by asking the audience, who of you does routinely EUS? So it's not all of you. I would roughly say for those of you who do not see in the bag that it's maybe 20%. So we will have a discussion at the end, but let me ask two short questions, Francisco. Is there any need and space for radial endosonography nowadays? Let's say that you start a new unit. Do you need to buy a linear scope only, or do you need to buy both scopes and be trained in both radial and linear scopes?
I think they are completely different approaches, the linear and the radial. I think if you are starting, you shall start with linear scope, as you have the ability to perform biopsies. It has a nice working channel, and you could perform therapeutics. A radial scope is completely different approach, only diagnostics so far, and we would like also to be able to perform therapeutics with the radial ultrasound endoscopy, but it's not possible so far. So my advice on that would be that you should start with a linear scope, and if you have interest, you may use also radial scopes.
So if you allow me, I will rephrase. If you can allow to have two scopes, buy both. But if you are allowed to get only one, then buy first your linear scope.
That's it. If you can afford both of them, it's nice. Also, radial scope is very, very funny exploration, if you let me know. It's total different view from the linear scope, but if you can afford only one, our advice, of course, would be to go to a radial scope that it's even cheaper.
So I agree with you that the development of lumen opposing stents really changed our ability to treat fluid collections or do other therapies by EUS. But when we come back to pancreatic fluid collections, is there any space for plastic stents still, in your opinion, or do we treat all our patients only with lumen opposing stents?
Yes, it's very it's old discussion about that. There are, of course, a place for plastic stents, but it's much more difficult to place them, although they are much cheaper. You have to put several, not only one. You have to put 2 to 3 plastic stents to achieve the complete resolution. But it's maybe to place those 3 plastic stents may lead you probably to 45 minutes job. Developing a lumen opposing metal stent, full deploy it, may take 4 minutes. So if you can afford it, I recommend lumen opposing.
Yeah, so the competition for plastic stents is really very big. So that they are in a difficult situation now. Yeah. We have one more question now, please.
Yeah. Congratulations on your talk.
Thank you.
You shown us this evolution of endoscopic ultrasound. My question will be not in terms of ultrasound endoscope, but in terms of expertise level. Do you think that anybody starting now ERCP training should be included in an EUS training, as we have seen how interventional it has become, and how a handy tool it is for the biliopancreatic management, disease treatment, even complex diagnosis? What do you think about that?
Yes, it's a good question. Thank you, Alberto. I think if they are starting, they of course should start both of them, ERCP and ultrasound, endoscopic ultrasound, as Though they share similarities, the lateral view, for instance, the management is quite different. So if you are used to perform ERCP and you know how to perform and you do it properly, after that, managing the ultrasound endoscope is much more difficult because movements are different, it's much more slight movements, little movements. But if you start training for ERCP, you should definitely start training also for endoscopic ultrasound.
Thank you, Francisco. I think we'll finish the discussion of this topic for now. We'll come back at the end if we have time. So thank you again for your great talk. We really enjoyed.
Thank you very much.
And I'd like to ask our second speaker, Dr. Herreros De Tejada. Sorry, I'm trying. And this will be on the optical magnification function of endoscopes, please.
Yeah, thank you, Thomas. Hello, everybody. I will. In a few minutes, I will show you from a clinical case my experience with the vision enhancement with magnification in order to complete a difficult ESD in the EG junction. This is my conflict of interest slide. And I will start with this clinical case. This was a 69-year-old male with a past of heavy smoking and drinking, advanced chronic pulmonary disease, and signs of portal hypertension with small esophageal varices. So he was referred to our center due to the finding of EG junction lesion between 30 to 40 millimeters with biopsies of high-grade dysplasia. Previous work out with CT and EUS show apparently a clinical stage T1B and 0, even including an endoscopic biopsy through endoscopic ultrasound. And to give you a first introduction, we know from large literature that in gastric neoplasia and ESD treatment, we need to properly select our patients to identify gastric carcinoma with the use of high definition and magnification in order to establish appropriateness of our endoscopic approach for this type of early neoplasia. In fact, actual guidelines, both European and British guidelines, also with the Japanese guideline, do recommend ESD as the first line of treatment for any lesion above 10 millimeters. So to first identify and then to establish the limits of a lesion, we need to use endoscopic evaluation based on regularity or irregularity and demarcation line of the lesion. There is this, with some years, the Japanese classification based on the vascular and superficial pattern. Basically, you check for regularity or irregularity, or even the absence of any pattern at all. As you can see, some examples of regular vascular superficial pattern, irregular, or totally absent. And this, it's algorithm that it has proved in Japan at least that it can give us a first approach with a high accuracy regarding two main steps when we see any suspicious lesion in the stomach. First is the demarcation line. Is there a demarcation line that clearly defines the lesion on the normal mucosa? And then the presence of any irregularity, either the superficial or vascular irregularity or both. So if we follow the algorithm, any lesion with a demarcation line, if there is no irregularity, if there is no demarcation line, of course, very low risk of any lesion down there. But even if there is a demarcation line, if there is absent total absence of irregularity, vascular and superficial, we can expect also a benign lesion with a high predictive value. But if we have both demarcation line and irregularity, it's expected to have a neoplastic lesion. So this is the basic scale in which you can manage, but you need the use of high-definition technology and ideally magnification to clearly establish these patterns. Together with selection and characterization of the lesions, also it is important to take into account this perspective of our endoscope to perform the ESD. It's very useful to use it to properly establish those limits of the lesion and to obtain an accurate resection, R0 resection of the specimen. So what is in our hands is to properly resect in a lateral demarcation line the whole of the resection. We know EG junction could be a tricky place to perform an ESD. From several reports, there is a slightly lower complete resection rate compared to other locations in the stomach. And of course, the more we include the esophageal, the distal esophagus, the higher could be the risk of stenosis according to the degree of the circumference we resect. So let's move on to our clinical case, in which I will try to show you the benefits of the new sonoscope, gastroscope with the zoom feature. Yes, first, the gastroscope that was used was the EG 550Z with zoom capability, and also the VIST, virtual chromandoscopy, which is based in the length of the light to properly select or be able to through the absorption of by the hemoglobin to establish the vascular pattern. So this gastroscope has several features. The angulation is significant. The working channel is 2.8. The size of the outer scope, of a distal scope, is quite small, considering this has a magnification ability of over 85 times with the zoom and with the chromandoscopy. And for this particular case, I used a speedboat ultraslim knife that is a bipolar knife with microwave ability to do hemostasia. So this is a video of the case. As I was explaining, again, it's a 69-year-old male with significant comorbidity, both pulmonary and also portal hypertension. And you will see now the first images once he was referred to our center, and we were doing the previous evaluation before ESD. There are several areas you can see slightly more redness with both in the EG junction and also in the distal esophagus. I guess it's running. Yeah. Okay. So those were the areas, and there was a bulky area on the opposite side in which we were not sure. And then using the VIST system with magnification, we started to evaluate both vascular pattern and superficial pattern of the lesion. And as you can see, you will see here, after doing the evaluation, we could see a demarcation line for sure in that particular area. It was a kind of a complex lesion, several areas connected. And here you can see the irregularity in the vessels. You will see on your screen thick vessels, and also pay attention also to particular areas where there is a vascular. There is no presence neither of vascular or superficial pattern. This is a retroflex visualization, which is quite a particular feature of this gastroscope in terms of flexibility. I didn't expect to to be so flexible, even with this magnification and thicker outer part. So in the end, we had a lesion extending some irregularity in the EG junction and distal esophagus. Now we move on to use the magnification feature also to help us to demarcate. Several times we had to correct our initial expectation of the limits of the lesion. You see clearly the demarcation line, but with the use of the magnification, it was easy to see along both the marking part and also through the ESD, as you will see. Here, for example, in the oral side of the lesion, you see we can notice kind of satellite area, which is also irregularity and also predicts cancer, just to extend our marking area to avoid excluding some part of the lesion. So when it was already marked, both upper and lower, you see it could take almost half of the circumference in the distal esophagus. So we start the ESD. This is the oral side. As you see, we keep some distance always also to the dot line to give us the extra amount of distal part of security line. Here, for example, you can use dynamically the magnification to have a proper visualization of the mucosa, how you're injecting, and also how you will be cutting. It's important to take this extra distance because we know for sure this type of tumors can extend below the squamous area up to 5 millimeters without no irregularity clearly seen in the surface. So this part is doing the lateral cutting in one of the sides. And as you can see here, I am performing the ESD in retroflex view, but with a quite significant control, even it's a very difficult area and it was a significant bleeding. This was the last part of the ESD, and you will see here the mucosal defect after the whole resection. It was around a 6 centimeter wider diameter, all the specimen. So final pathology, unfortunately, was not good enough. There was an endocarcinoma with a mixed G3 plus G1 and with vascular invasion on vertical margin invasion. Nevertheless, at least in what's corresponding to our lateral margin, we could at least establish well the limits of the lesion. So those factors were out of our control, of course, and the patient was then discussed in a multidisciplinary committee in the referring center. So just to finish, what is my experience regarding this gastroscope for ESD in a difficult situation like this? Well, first of all, I was surprised by the maneuverability of the endoscope. Even with this narrow diameter, the working channel, and keeping this magnification ability, it was very, very responsive. I could move easily. Even with a lot of bleeding episodes, I just saved you from the video, but it was kind of a nightmare at the beginning. And also the quality of the image. So as a whole, it includes not only the magnification, which is very useful, but also the whole quality that allowed me to perform the full procedure and taking decisions then and there along the limitation and through the ESD procedure, clearly to define the margins and to take decisions there, like as you could see, where there's micro lesions, satellite lesions, that should be included also in the specimen of those suspected areas. So this is a summary of my experience, and without further time, I'm open to questions. Thank you.
Of the technology, maybe I would just start by adding to your last slide that I also had an experience a chance to briefly use the endoscopes, and I really also appreciate the great reflection ability of the endoscope, which I think, especially for treatment for therapeutic cases, is, for example, endocardia, may be of key importance, and actually a limitation for scopes that do not allow this.
Yeah, certainly.
Yeah, this is very important, and also had a chance to see the EUS scope, so we'll get back to it. And also, I think it's also a very sort of soft scope, allowing a very good maneuverability. So before we get more questions, are there any questions? Yes, please.
There's a microphone.
Please, if you can come up to the microphone so that everyone also in the bank can hear.
Sorry. Congratulations for your nice presentation, very beautiful image. Do you think, Alberto, there is some use for the magnification, not only for the study of the lesion, but once you are in the submucosal space, there is some use for that, for maybe clarification or so?
Yes, I think, and in fact, I commonly use it, what any type of magnification or real magnification, as in this case, along the ESD. Sometimes you need to, you keep a close vision and you need a clear image. Sometimes it gets blurred if you are too close, but you really need to see where is that vessel that is in the submucosa to identify. Yeah, it's part of the, it's a really helper. A thing to have along the ESD, not only for diagnosis. Yes.
Well, thank you.
Okay, if I may ask or go ahead if you want. Did you have a question?
Yes.
Please.
Thank you very much. It's a nice presentation. And I would like to know, when young endoscopists are starting performing ESD, they always want to take the scope and start cutting. But before that, how many time do you think they shall dedicate to perform optical diagnosis before achieving the cutting?
Well, to tell you the truth, the problem may be that even the faculty members in our environment are not so used to use magnification. So it's difficult to promote magnification use when us are not so used. But in ideal world, first, basic white light examination of the stomach and the esophagus is key. The use of virtual chromandoscopy, and if, depending on the type of scope you have available, different models you have, either you can have access to what is called near focus in the system of Olympus, or magnification in the system Sonoscape, or Fujifilm. Almost all have. So you have to try to convey to your trainees or your fellows that doing an evaluation is a full complex or extended process in which starts from the beginning, from how you clean their stomach, how you take time to see it, how you secure your patient situation to make it possible with sedation, and then how to use this magnification, how to check. It's impossible to know, I mean, all the details, but this difference is this demarcation line and irregularity. Both things together take a biopsy. Probably you have an aplastic lesion. Yeah, not to miss it. It's a process.
Thank you. And if I, because we are coming to the end of the session, I would still like to ask the last question to Francisco, and that is what is your personal experience with the very Sonoscope EUS technology and endoscope and processor and imaging? If you could maybe summarize quickly so that we also get some information on this thing.
Yes, we are, I think we all that perform endoscopic ultrasound with Sonoscape equipment are really pleased with the image quality and even with the maneuverability of the endoscope, as it's really easy for us to get to second duodenum portion. It's very, very easy. The maneuverability is quite good, and it has been a nice improvement since the first time they developed the endoscopic ultrasound with the second one that is raised now. And you know, Sonoscape, it was in the beginning an ultrasound company, so they have quite experience in ultrasound. So they have quite good image quality, and even it's been going better only by software. Also with hardware when they develop a new equipment, but only with the software engineer, they are getting much better quality images.
I have to say that from my very little experience, I fully agree with Francesco said. And so my feeling from using the scope very briefly was also fantastic. I guess this also applies to therapeutic procedures. The good maneuverability also then increases, I think, the chances of getting a biopsy from difficult spots or getting access to...
It has really good maneuverability, but is feasible and it's reliable for very little movements, as we need sometimes to take tricky biopsies or to perform cyst puncture when they are little ones, but we suspect something that must be punctured. They are really reliable.
Thank you. So I think that we have really heard very objective evidence that these scopes, sonoscope, endoscopes, either endoscopic ultrasound or gastroscopes, are really of very high quality and make our work easier. And I think this is a nice statement at the end. I would like to also, of course, thank Sonoscope for inviting us, our very distinguished speakers, to share their experience with these endoscopes and their great lectures. Specifically, Yui for her great invitation and great personal approach and hospitality that we all enjoyed, and all of you for coming and being with us. And I think we have all learned a lot, and we'll now start thinking about getting sonoscopes, endoscopes into our practice. Thank you. Enjoy the rest of the meeting.